All right, let's dive right into the IBD Civil War. Think of this as a battle raging inside the gut, an autoimmune conflict with strict rules of engagement. First up, you've got Crohn's disease. We're going to call this one the transmural rebel. And that word, transmural, is everything. It means this disease punches straight through the entire gut wall. It can pop up anywhere from the mouth all the way down to the anus, and it attacks in these random patches, leaving behind what we call skip lesions.
Now, on the other side of this war is the other faction, ulcerative colitis, or the mucosal dictator. Unlike that unpredictable rebel, Crohn's, this one is much more methodical. It's confined to the inner layers of the colon, just the mucosa and submucosa. And its pattern of attack? Totally predictable. It always starts in the rectum and just marches its way up the colon in one single continuous battlefield. Seeing these two as completely different enemies is absolutely critical.
And you know, the collateral damage they leave in their wake? Totally different signatures. With Crohn's, you're looking for things like non-caseating granulomas, nasty fistulas, and even kidney stones. For ulcerative colitis, the telltale signs are crypt abscesses, a dangerous association with primary sclerosing cholangitis, and a seriously elevated risk of cancer. You have got to know these differences for your exams, so let's get into the intel.
But first, before we dig any deeper, we have to pause for a moment. Please be aware, this content is designed purely for educational purposes, specifically for those preparing for international medical exams. This is not and should not be considered medical advice for clinical practice.
Okay, let's analyze some battlefield intel with a classic case. So you've got a patient, chronic diarrhea. You do a biopsy and it shows crypt abscesses. Then the blood work, the serology, comes back and it's positive for p-ANCA.
Now, with those two pieces of intel, crypt abscesses and p-ANCA positive, the intern on the case orders a small bowel follow-through. That's an imaging test to check out the small intestine. So here's the question, the one you're going to see on your exam. Was that the right call? Is that a logical next step?
No! That is a classic board exam trap. And why is it a trap? Because crypt abscesses and a positive p-ANCA are the absolute gold clues for ulcerative colitis. This intel is screaming at you that the war is being fought only in the colon. Ordering a test to look at the small bowel is a waste of time and resources.
Remember, ulcerative colitis lives in the colon and rectum. It basically never involves the small bowel. Now, if that biopsy had come back showing non-caseating granulomas, the undisputed hallmark of Crohn's disease, then ordering a small bowel follow-through would have been a brilliant move.
And this brings us to the serology shunts. The lab results give you the answer key. If the marker had been ASCA, you'd be thinking Crohn's. And yes, you'd investigate the small bowel. But our patient was p-ANCA positive. So the takeaway, the thing you need to burn into your brain is this. ASCA is for Crohn's, p-ANCA is for UC. Simple as that. Don't go hunting for Crohn's when the labs are shouting ulcerative colitis.
Okay, switching gears. We have to talk about another huge trap the board exams love to set. This one is all about surgery. You've got to understand the curative trap and the stone trap, or you're going to lose easy points. Here's the lethal mistake people make. They think surgery is the final answer for both. Wrong. For ulcerative colitis, surgery is absolutely curative. Why? Because the disease is only in the colon. You take out the colon, you've taken out the disease. Game over. But Crohn's, that's a systemic disease. It's everywhere. If you cut out a bad piece of bowel, it almost always comes back, usually right where you made the new connection.
And there's a second trap, a really sneaky one involving kidney stones, and it's specific to Crohn's patients. So how does this happen? Let's walk through it. 1. Crohn's loves to hit the ileum, which messes up fat absorption. 2. All that unabsorbed fat floating around in the gut binds to calcium. 3. This leaves oxalate, something we get from food, all by itself, totally free to get absorbed into the blood. And 4. All that extra oxalate floods the kidneys, and boom, you get painful calcium oxalate stones.
Okay, let's pull all of this together. It's time for the master matrix. This is the neural encoding protocol. We're going to lock these key differences into your long-term memory right now. Let's do a rapid-fire rundown. For Crohn's disease, the depth is transmural, which gives you fistulas. For UC, it's just the mucosa and submucosa. Biopsy for Crohn's, non-caseating granulomas. For UC, crypt abscesses. Serology for Crohn's, ASCA positive. And for UC, p-ANCA positive. A key complication in Crohn's, those calcium oxalate stones. For UC, the dangerous liver condition, PSC. And finally, surgery. For Crohn's, recurrence is the norm. For UC, it is curative. Got it?
And with that matrix locked in, you now have the definitive logic to tell these two conditions apart. Your command authority over this topic is officially secured.
The inflammatory matrix is now sealed. But inflammation is just one piece of the GI puzzle. The next battle, the war for understanding absorption, is about to begin.
So, are you ready for the next mission? Can you spot the architectural decay of celiac disease on a biopsy? Do you understand the tricky logic of the D-Excelose test? If the answer is no, then you're not fully prepared for what's coming.
And that is exactly where we're headed next. Proceed to our next explainer, Series G 2.2, the Malabsorption Refinery.